This video is designed to help families and doctors make joint medical care decisions for patients who have lost the mental capacity to make decisions for themselves. Usually when a patient is admitted from home with an acute illness, they may be extremely confused or in an unconscious state and perhaps go into intensive care. With an intensive care specialist, we'll always discuss issues of consent and life support with the family or person responsible for making decisions. In nursing homes it's slightly different, and family doctors really need to take a more active part in this and get their secretaries to ring a family member to come in and discuss the care of a newly admitted dementia, Alzheimer's or vegetative state patient. When I discuss with families, I like to cover 5 areas. The first area concerns making sure that families understand that they have choices in treatment, and that's their legal right in most states through the laws of consent to consent or refuse to treatment. They need to know a little bit about various life-prolonging treatments and the choice between those and palliative care. By this I mean strong analgesia, sedation and good nursing care. The second area I cover is about the nature of life-prolonging treatment. Most people understand that in hospitals, life-prolonging treatment often involves life support machines, cardiopulmonary resuscitation or CPR in the case of cardiac arrest, intravenous treatment in terms of drugs and fluids, emergency operations and other treatment. However, one has to understand that in nursing homes there are also a lot of life-prolonging treatments that are prescribed. These may include antibiotics for serious infections, blood pressure tablets, cholesterol tablets, blood thinning tablets to prevent strokes and heart disease, immunizations to prevent flu and pneumonia, and importantly nutritional supplements which are used to prevent and treat weight loss in vegetative state patients. It's worth noting that many of these treatments used in nursing homes are equally effective as hospital treatments in prolonging patients' lives. The third area I cover is about the outcomes following illness. As I've said before, people who come in from home with pneumonia or septicemia may be acutely confused or even unconscious. Hospital doctors often discuss with families the sort of outcomes which may range from full recovery to return to home, maybe a small or partial disability, perhaps a severe disability, either physical or mental, or that the treatments in fact may be futile. And by this they usually mean that despite active and aggressive treatments, the patient is likely to die anyway. In nursing homes, because a large majority of them are actually suffering with severe dementia, Alzheimer's and vegetative state illnesses, the situation is slightly different, because what one really needs to understand is what is the underlying natural course of these illnesses. The course of Alzheimer's or dementia is characterized by 3 main things. Firstly, even after admission to a nursing home, it is a very long illness that can last several years. Secondly, dementia is not just an illness of deterioration of intellectual capacity. It is also, in its later stages, a severe deterioration in their physical health. So that all of these patients eventually become bedridden, they have to be spoon-fed, they cannot communicate, and they are doubly incontinent. The third and important issue, it is accompanied by what's known as intercurrent illnesses and behavior problems. By this I mean it's because of the length of time this illness lasts, there are other illnesses supervene. So people can get pneumonia, cellulitis, urine infections, fractured hips, cancer, etc., as well as having behavior and problems with aggression problems. Many families will find this a very difficult issue to handle, and it can be quite emotive when discussing this subject. I'm just going to show you a timeline of a fairly typical Alzheimer's patient in a nursing home. One can see how the illness develops over time with various problems interceding over the years until they eventually become a vegetative state type patient. For some families and individuals, the question is more about the quality of life rather than the quantity or length of life at this stage, whereas for some families it is life itself is all important. There are several important things to remember about life-prolonging treatments. Firstly, by stopping them, it may actually make no difference whatsoever. So if you stop blood pressure tablets, it may make no difference to the person's life expectancy, for example. However, on the other hand, particularly if people are on several different treatments, such as blood pressure tablets, cholesterol tablets, blood thinners, they have flu vaccinations, or on nutritional supplements, they're likely to live far longer than somebody who doesn't need these sort of things. The other issue is one has to remember there's always a risk in stopping treatments. Although it may be acceptable that the patient may die because you are stopping further suffering, the patient may not actually die, but the patient may suffer, for example, a stroke or pneumonia as a result, and would have to then live a more disabled life. But at this point of time in their lives, this may not be a huge issue, and people may be willing to take these risks. The fourth issue I discuss with families is to try and assess what the patient themselves would have wanted if they could see what was happening to them now. This is sometimes called contemporaneous substituted decision making, and it's assessment of someone's beliefs, values, and life goals. Did they give any oral directive about what should happen if they ended up in a nursing home? Many elderly people tell their relatives that if, for example, they are in a vegetative state, they want to have euthanasia. Obviously that cannot be offered, but if that were their statement, there would be no reason to give them life-prolonging treatment at that stage of their illness. There are also specific religious and spiritual values that would impact on this sort of decision. And many families have already been through this sort of process with other family members or friends and understand inherently some of these questions. There are several questions that I would pose to families. Would their relatives find their level of physical and mental functioning acceptable to them? Would they feel that they retained enough of their personality and spirit and would continue to value life in its present form? Despite their loss of personal dignity and independence, would they feel that life would still be worth living? Would they have any religious or spiritual convictions that would impact on this decision? Would they believe their best interests be served by treatment to prolong their lives rather than letting nature take its course? Fifthly, I often discuss the use of a palliative care directive form. This is a form used for family to sign if they really only want palliative care and have decided that they no longer want any life-prolonging treatment. It deals with several important issues. Firstly, consent for hospital admission, which is for palliative care only. Secondly, consent for antibiotics for minor illnesses like skin infections, urine infections, or for public health reasons. Thirdly, to refuse consent for all life-prolonging treatments, whether it be CPR, blood pressure, cholesterol, blood thinning medication, immunizations, nutritional supplements, etc. And fourthly, cessation of routine monitoring, such as blood pressure monitoring and weighing. Many of these are a little pointless if you've already decided the patient is only for palliative care. That doesn't exclude doing this sort of monitoring if there is a clinical issue to attend to. At the end of the consultation, I usually give the families a copy of a 2-page leaflet about medical care decision making or substitute decision making. There are 3 important reasons for doing this. Firstly, it can be an emotive consultation, and patients and families don't always remember the details of it, so they can go and peruse the information later in their own time. Secondly, they can also hand the leaflet to other members of the family who may have a say in future treatment. And thirdly, there are good medico-legal reasons for giving them written information and recording that fact in a patient's notes in order to stave off any complaints of failure to act. I have been practicing like this for many years and have never actually had any complaints in this regard. If they do decide to fill a palliative care directive, it should be placed prominently in the patient's notes so that if the treating doctor is away on holiday or at weekends, other doctors are aware of the family's wishes, and also all the nurses in the nursing home are aware of their wishes. And the copy can also go to the hospital with them if an admission has to be arranged. Let's go back and have another brief look at the timeline. With the traditional method of consent, often treatment is stopped very late in the day, maybe a few weeks before the inevitable death of a patient from a vegetative state illness. The five-step process I have discussed differs markedly from a more traditional way of discussing consent to treatment issues. My impression is not only do families feel they are valued as partners, but it tends to unite families around the perceived wishes of the patients, and commonly there is a greater acceptance that life-prolonging treatment needs to be stopped earlier rather than later. But if you use a five-step process, most families will come to an agreement that life-prolonging treatment is stopped much earlier in this illness, really on the basis that the patient would not have wanted such treatment, and they would not want either themselves or the family to suffer whilst they have to live through it. In brief, these are helping families understand that they have the right to refuse life-prolonging treatment and choose palliative care if they wish, giving them information about the nature of life-prolonging treatments in the 21st century, and remember, it's not just about CPR and life support options, helping them navigate the meaning of prognosis or natural course of illnesses, in particular in dementia, giving them confidence in assessing what the patient themselves would have wanted by understanding their values, beliefs and goals, and finally, using written palliative care directives when life-prolonging treatment is no longer wanted. I hope you've enjoyed this video on medical care decision making for families, and you'll find the information leaflets for medical care decision making and the palliative care directive form on the following websites.